Good evening, and thank you very much for attending this course. Welcome to the course of No Capsule, What to Do with the IOL. And as you know that the open posterior capsule is one of the most common complications during phacoemulsification. And here, by opening the posterior capsule, you lost the barrier between the anterior and posterior segments of the eye. So once you lost the barrier between the anterior and posterior segments of the eye, which is in the form of posterior capsule as well as the anterior hyaloid face, here you have some difficulties and consequences. For example, after losing the barrier, the vitreous might prolapse inside the anterior chamber, and the leuco fragments might fall down in the posterior segment and complicates your surgery. So again, if you just pull out this fingertip, this will invite more vitreous, and this more vitreous will do stress on the retinal periphery of the retina and might cause retinal detachment. So suppose that you just did complete vitrectomy and you have now open posterior capsule, and what about the IOL? What are you going to do with the IOL? This is the aim of the course. So now it's not planned. This is the real life scenario. There is no plan, and you have just a routine phacoemulsification case, and it ends up with an open posterior capsule. So some cases, if you have enough capsular support, like in this case, if you are lucky enough, you have just tear in the posterior capsule, mainly in the superior half, and you have large remnants of the posterior capsule, mainly in the inferior quadrant, so you can still implant the single piece IOL in the capsular bag. And if you have sometimes a large break from equator to equator, but on the same side, and on the other hand, still you have enough pockets on either side from the posterior capsule and the anterior capsule, so still you can implant a single piece IOL in the pockets, although there is an opening in the posterior capsule. Or if you have a large break like this, you may implant, of course, the safest is to implant a 3-piece IOL in the sulcus and do optic capture if you have an intact rhexis, or you can implant a single piece lens, and we are experienced with the reverse optic capture. But suppose that you don't have enough capsular support. So if there is no capsular support, what to do other than anterior chamber IOLs? Because we do care about the corneal endothelium. So what to do in this case if you don't have enough capsular support? So let's start our course by introducing, you have a bunch of renowned international experts in the scleral fixation and different types of fixation of the IOLs. Let me introduce Lukan Mishev. He will talk about the IOL fixation using Gore-Tex suture. This is followed by Sergio Ganaprava. We hope that he will come soon. He will talk about, of course, the IOL fixation using Prolene suture. And of course, Priya Naran will talk about the glued IOL technique for intrascleral haptic fixation. And Vladimir Weiner will talk about the flange haptic Dayamani technique for intrascleral haptic fixation. So according, and then Carlo Carnevali will talk about the fancy lens that he made by himself. This is the novel lens for intrascleral haptic fixation. If you have the chance to get this lens, or you have predicted that you might have a problem in this case, and you have the lens available in the OR. So let's simulate the real life scenario that you have a routine case and ended up with an open posterior capsule, and you are not lucky enough to have enough capsular support, and there is no posterior capsule. So what to do? According to the situation in the OR, if you have access to Gore-Tex suture, we'll learn you how to fix this lens with the Gore-Tex suture. If you have an access to the Prolene suture, we'll learn you how to fix this lens with the Prolene suture. If you have access to 3-piece IOL and 27-gauge needle or whatever, you will learn how to fix this lens with the Scleral and or with the glued IOL technique if you are going to do the glued IOL technique. Or if you have the access to this novel lens, which I do believe this is the future of the era of the scleral fixation techniques, so you learn how to fix the new Carnevali lens. So let's start our course with the Lukan Mishev. Thank you very much for accepting the invitation, and he will talk about the Gore-Tex suture for the scleral fixation IOL.
So Dear colleagues, thank you for being here on this late afternoon. Thank you, Professor Asa, for inviting me to present in this course. I will talk about the possibility to fixate IOL on the sclera with Gore-Tex sutures. Whatever is the scenario, we are in a phakic condition, and sometimes we might not have particular lens as Carnevale lens in order to address the situation, but we might have a lens with suitable design to be used as Gore-Tex fixation. Here are my horizontal scleral pockets, which are done on 3 mm from the limbus, and then the tunnel is advanced to 2–2.5 mm from the limbus. The idea is to cover the suture with sclera in order to not be seen at first under the conjunctiva and to avoid any erosion of the conjunctiva. This is not actually the case with Gore-Tex because the Gore-Tex is tissue forgiving. But anyhow, it's more aesthetic and I think more sure that sutures to be covered under the sclera. The other thing is that this will address the possible hypotony after the surgery also. So with 23 gauge MVR blade, I made 2 incisions on 2–2.5 mm from the limbus. I'm using 23 gauge, and then I will use instruments which are 25 gauge, because if you have a tight entry wound and you use large instrument, you might involuntarily induce psychodialysis, which will be also an issue in the post-operative period, and you will have hypotony, and you will ask yourself if the wounds are leaking or what happens with the eye. So here I'm using a handshake technique, and this is the basic difference between the colleagues which introduced years ago Gore-Tex fixation and my technique. Because I don't open the sclera, I don't pass the sutures outside the eye and then implant put the sclera of the cornea, then implant the IOL through a, let's say, 5.5 or 6 mm corneal opening or scleral tunnel. Here I stay with 2.2 mm, and with micro instruments, of course, I would advise to use micro instruments for anterior segment because they are curved and they are more convenient to work in these complex maneuvers. If you are using, for example, vitreoretinal forceps, it's straight, and sometimes from the temporal side it's easy, but from the nasal side it might be difficult because of there is no curvature of the instrument. So here the trick is to pass carefully the Gore-Tex suture through the eyelets of both haptics, and then carefully, of course, to pass the lens behind the iris. Obviously here I'm after vitrectomy because, as Professor Assad said, it's important at least to clear the anterior vitreous. I mean around the basis and the anterior highlight. This is the other side. Again, the same openings with 23 gauge MVR blade. It's angled blade, again because I think it's more convenient. This is 25 gauge microforceps with suitable haptics. And have in mind that the action of the jaws should be vertical, not horizontal. There are certain instruments which are microforceps but with horizontal action, and it is not convenient because you need to twist your hand in order to engage the suture. In my personal opinion, most of the maneuvers in the anterior chamber are done with vertical jaws, not horizontal ones. So just have it in mind. So here again with the handshake technique, I pass the suture through the eyelets of the optic, and then what I like with this technique is that you can titrate the position of the IOL. You can of course centrate the IOL, which means that you might implant the AO, which is zero aspheric lens. So it's forgiving with decentration. But if you're a little bit more advanced or more confident, you might implant EDOF lens as a caution loan. Looks smart, no commercial interest, from my side, but you can do it and you can achieve a little bit more glass independence even in such complicated scenarios. So I would advise the first not to be 3 or 4 throws, and then to make at least 2 one throw. The Gore-Tex is really elastic. You might cover it with the Scleral. If you want, you can push it even into the eye, but I think it's not necessary. Here is another complex case. This is a young child actually, and here I'm implanting the EDOF lens, which is with the same design. Basically the approach is absolutely the same, but here the eyelets are more open, so it's more easy for the surgeon. This is the Gore-Tex suture. It should be CV8. It is really difficult to be found, but it's 8.0 as a size, and it is thin enough to be used in ocular surgery. Again, the same handshake approach, and again the same horizontal scleral pockets. Why I show this? Because here I already made some of the iridoplasty, and we need to preserve this fragile construction. And anyways, I will be able to Gore-Tex suture this IOL without damaging the rest of the iris or the delicate structure that I try to create, because I will try to finish it with fairly good aperture size. So I need to create some pupil here. You need to be careful, and the instrumentation is mandatory. If you are not prepared with microforceps, it will be more difficult. Not impossible, but more difficult. Here, with 2 side ports and 2.2 millimeter plane incision, you can do it without enlarging the cornea or corneal incision, or without making a scleral tunnel. So carefully you reposition the haptic, and the last haptic here. Again, the same handshake maneuver. So you can even use a second instrument to protect the iris and to guide the suture passing. And again, I will be able to centrate the lens according to what I think is the proper place in the eye. Again, you can rotate the knots under the scleral flaps, and later on they will not be visible. And here with the 6er sliding knot, you can finish the iridoplasty in order to more or less make a pupil here. And last but not least, this is a case of Carnaval IOL, which I misloaded, or there was a mistake in my loading in the cartridge, and my trailing haptic will be torn. So I think that the maneuver with the horizontal scleral pockets and the Gore-Tex might be used here also, because the design of the lens is really clever. You have 4 haptics actually, plus 2 anchors. The aim of these haptics is to sit on the sulcus, and I can use these haptics exactly the same way as with the AO lens. Here you can see that there is no trailing anchor. So what we do now? Do we expand the lens, or we try to, let's say, suture it? We need to suture it symmetrically to the other position of the IOL to avoid any tilting. So my approach here would be to ask my colleagues to give me the Gore-Tex suture. And again, with the same maneuvers. Yeah, sometimes it's difficult to find the sclerotomy. And here even it's easier to find the eyelet. Sometimes it's not so easy to handshake the other instruments. So the same trick here. In my opinion, in aphakic conditions, we need to have an armamentarium of different approaches according to what we have as backup IOLs in the operating room, backup suture materials, and of course our ability to do the technique. So I really like this course which Professor Assad organized. We will see today almost all the techniques which are available to handle such a complicated situation. So sometimes it's a little bit tricky. I must say that the Gore-Tex suture is not good to be cut with scissors. It's better to put the suture and use a knife, keratom or something like that. It is more easy to cut it. Otherwise, the scissor smashes the Gore-Tex because basically this is a Teflon and it is difficult to be cut. Now, again, the same thing, and we finish the case in fairly good position. Thank you for your attention.
Thank you very much.